I have 40 slides, like I was mentioning to the group earlier before we came on, but I'll try to go through them quickly. The whole point is hopefully to interact and just have some tidbits and highlights. So I think we are recording. Is that right already?
Yes, we are.
Okay, sounds good. Sounds good. So here, so I'll get to it. I think for folks, please feel free to actually verbally say stuff. I know sometimes on Zooms people are just exceedingly quiet. Feel free to pop in and jump in, or put stuff in the chat. And again, I'll try to keep it relatively sparse and relatively quick so we can have a chance to actually talk. So so my name is most people just call me Raj because Debraj Mukherjee is a bit of a mouthful, but it's really an honor and a pleasure to be here. I think my interest in neurosurgery came up, to be honest with you, after medical school. After medical school, I went to School of Public Health at Johns Hopkins, thinking I was going to be a cardiologist. And when I was there, it happened to be a family friend developed a tumor, brain tumor. And so I reached out to the group at Hopkins, and it happened to be that there was a really nice guy at Hopkins named Alfredo Quinones, who I think is on your Instagram page and all that kind of stuff. And so we talked a bit, and he said, "What are you doing here?" We ended up working on some projects. I went to the operating room with him. He became my mentor, and it's really because of him that I'm here. So I happen to have his old job since he went on to Mayo to become the chair, and so it's I think a lot of all this stuff about being successful in neurosurgery and all this kind of stuff, and just in life, comes from working hard, having a being sincere. And having a lot of really good mentors. And so if nothing else, take away from this my email address, and feel free to reach out anytime. Okay, Dr. Q, I owe him my career, and anything I can do to pay it forward would be an honor and a pleasure. So anyway, with that, let's see. So I have no disclosures. I don't know if I have to go through that, but there's two sort of sections that I wanted to go through. One was early engagement, especially for folks that are early in medical school, or even prior to that. And then some specific data points that you can hang your hat on what you need to do to actually match, just based on the data. Sometimes people sugarcoat things, but there's at a certain point, like, you got to just hit some marks. What score do you need to get on your USMLE? How many publications do you need? That kind of stuff. So with that, we'll start with early engagement. I think there's good data from the general surgery literature and from neurosurgery as well, that just getting exposed to the surgical field really helps. It makes a difference. And so in terms of the study out of University of Wisconsin showed that it was really interaction with faculty, with residents, being in cases, not just observing but participating, that is really what pushed people into the field. And there's a pretty high rate between those that are interested in surgical fields in their clerkship and those that end up actually matching. So once you get people interested, they seem to come in high numbers. And particularly, it can be difficult as a medical student to talk to attendings and to get engaged. And so this paper also out of Wisconsin shows the impact of having surgical resident teachers, connecting more so with the residents even than the attendings. So the lower numbers here, the higher, the lower your numbers, the closer you are to one, the better a teacher you were. And so folks that, medical students that went into surgical residency had much better, experiences basically with surgical residents than those that did not go into surgical field. So as part of it is a bit of the luck of the draw, but mentorship is not just for attendings. Mentorship can also be attained by connecting to those just above you in residency. And those that are particularly good, those that were the ranked amongst the top sort of residents, had a really high association with students choosing to go into the surgical subspecialty. So usually everyone knows who are the sort of the friendly and the approachable residents, and seek those folks out because I think they have a lot to teach. I think as we look at different interventions that different schools have pursued in Ireland, they did an intervention where they basically just exposed students who weren't normally exposed to neurosurgery onto that clinical onto that clinical service. And the things that they found were those who didn't have, or weren't exposed to neurosurgery versus those who did. Those who did had markedly better understanding of the clinical advances that folks in that the field of neurosurgery has made. Those who didn't rotate, the majority of them thought that our patients had poor outcomes and that there were limited interventions. And while it is true for sort of end of life issues, there's a lot of folks with, back pain, spinal issues, functional neurosurgical issues, tumors, benign tumors like meningiomas, that we can really help a lot. And so some of that exposure, just having the exposure to the field really helps people a lot. And so especially for those of you early in your medical school training, seek out those experiences because it really does make a world of difference. And this was another study that was done in London where they tested people basically after having just a small little lecture series, some small workshops and teaching sessions, the kinds of things that honestly your interest group is doing. And what they found was that there was a significant improvement and a significant change in the perception of the field. Beforehand, a lot of the students thought that they were, it was essentially an impossible lifestyle, really long and arduous training, male dominated. And after they got exposed to, the diversity of cases, the diversity of outcomes, the diversity of people in our field, there was marked sort of improvement, a better understanding that, yeah, even though lifestyle is still tough, that was the one thing that stuck. A lot of other things, a lot of other aspects that people were concerned about the field, a lot of those fears were alleviated. This is just some other data about, small little pilot interventions. Literally, this was a 6-week course for medical students, and their knowledge was significantly better, 90% versus 5%, 70% versus 40%, in terms of, just simple things like how to diagnose increased intracranial pressure and shunt failure and those kinds of things. So even small interventions improve your knowledge, as well as we saw earlier, sort of help people's enthusiasm for the field grow. I'm going to skip through some of this. Basically, all this is saying Dr. Sawaya, who's a really prominent neurosurgeon who's recently stepped down as chair at MD Anderson, talked about their efforts to engage students, not just fourth-year students, but students earlier in their career. Hopkins has a similar integrated model across all 4 years where, the neurosurgeons like myself will come in and teach anatomy, where the residents will be teaching assistants, where we have grants that help students engage in their summer between first and second year. All third-year students are offered a 2-week rotation, so it's not just on your sub-internship, because if you have to wait till your sub-internship, the cat's out of the barn, or the horse is out of the barn, or whatever that expression is, so it's in summary, all of this work shows that, the earlier you get engaged, the more likely you are to have a better sense of what you're getting into, and secondarily stick to it. The Hopkins model of engaging people early, it literally goes to the high school level. So about 10% of the students in our lab are actually high school students, and that goes all the way up to those who have completed residency. And there are actually 11 chairs of neurosurgery across the country now who have sort of come through our model that Dr. Brem, who's our chair, really established in the mid 80s. Some examples of specific things that you can do in Mexico in your specific school include following the Rutgers model of having residents engage with medical students early on with interest groups, even if early 2-week elective experiences, even in the first and second year, and an early introduction to research opportunities. The way it worked for Rutgers is they had this program introduced in 2002, and the number of publications really skyrocketed for them. It led to a huge number of publications, and even though it looks like their abstracts fell off, it was actually because they were focused more on publishing in these years than just putting together smaller abstracts. So a little bit of concerted effort. It does take a couple years to sometimes reap those benefits, but those benefits can really be huge, as you can see. By the way, I will stop for a moment. Any questions or concerns or any thoughts sort of come to mind as I'm going through this? If so, please speak up or put it in the chat. This is some additional essentially neurosurgery interest group kind of data over just a couple of years at University of Pittsburgh. And their membership in a couple of years almost doubled, and a lot of that reason for that is because they had regular interactions. They had regular meetings, even if they're, relatively small groups of people. It doesn't always have to be 100 people, but those, 10 folks weekly over years led to really marked improvements in interest in neurosurgery and eventually people matriculating. This is another paper out of Vanderbilt Medical Center that basically shows that after they did a structured elective with a didactic session on it, all of the markers that had to do with what students thought about neurosurgery, about the lack of collegiality, that improved. Quality of life assessment improved, the work-life balance improved. The only thing is everyone did agree that it is difficult training. I mean, there's not getting beyond the facts of it, but all of those markers that have to do with the sort of softer side of neurosurgery improved by just having a little bit of exposure. This basically is a paper that one of the prior, a current Pittsburgh resident, and some of the folks in the group here at Hopkins came up with, where we assessed the impact of a medical student interest group like your group over the years. And so there's a lot of different ways that groups have been engaged, especially in this COVID era, as you guys are doing with this webinar. I think this is a great way to get mentorship, to get interaction with neurosurgical groups from really across the country and across the world. You can also do anatomy labs and little simple skill-based labs, didactic lectures, ways to interact like we're doing now, and research forums. And I'm happy to talk about some of the ways that this can get funded and just some of the particulars about getting it off the ground at any point. Over the last handful of years, the number of AANS interest groups have really skyrocketed, as have the number of members per chapter. And we're really all across the United States and increasingly across the world, including in Mexico City and Guadalajara, and obviously your institution too in Monterrey. The number of attendees per group have improved as well. And with that, we're seeing more and more interest in really exciting young people who are interested in the field getting involved early. With regard to improving recruitment, we recently sent out a survey to all the program directors in the country. We had a pretty good response rate. About a third of folks responded. And the areas that seem to be most amenable to improving recruitment into neurosurgery really happen to do with clinical rotations and early preclinical exposure. Only half of institutions across the country had exposure to neurosurgery in years 1 and 2. And so what we know from the data is that the more publications you have, the better mentorship you have, the more likely you are to match and be happy with your match. There aren't a huge number of students that match every year. So on average, there were about 3 applicants per year, or 3 rotating students, I should say, per year. And 1 to 2 applicants actually match at these programs. So it's still a relatively exclusive club, but there are ways to get into that club, and that's what I'm going to be showing you in a bit. Again, anatomy labs, curriculum, and neurosurgery interest groups have been shown to be really outstanding ways to get involved. Rutgers and Hopkins have some data out there, and I'm happy to talk afterwards about some of the ways that we've gotten a lot of rotators to come to our institutions, and secondarily, how we've matched a lot of folks. Didactics, again, are a great way to get involved and to drum up interest. Mentorship programs that are structured, anatomy labs, and interest groups. So the bottom line for this first bit is it's important, if possible, to engage early and often. Even minimal interactions with residents, attendings, and other folks help. A structured curriculum is a great way to improve your knowledge base and to make connections, especially in this sort of COVID world. And it's important to get into the anatomy lab and try and do things to try and get your hands dirty with skills-based labs and anatomy labs. So that's one bit. Just so I don't completely blabber on here, oh, by the way, yeah, someone wrote Dr. Q is awesome. He is awesome. Yeah. Any thoughts, questions, concerns about that bit? Are there a whole bunch of folks that are early on? Are most people 3rd and 4th years? Anna or anyone else? Who's on the call here?
I am 2nd year, but it's not US 2nd year. I am 2nd year for a 7-year program.
Oh wow, okay. So that's right out of high school, right?
Yes,
Got it. Got it. Got it. Okay. And when do you do your research years in those 7 years?
we
Or do
don't.
you have any research years?
We don't.
You
Uh,
don't. You don't. Okay. Okay. Yeah. In the States, sometimes people will take a research year or so to either do a PhD or to get more research under their belt. And, as you'll see, on average, it tends to be if you have, 10, you need to have 10, 15 abstracts, publications, those kinds of things, in order to increase your odds of matching. And, it's a little tricky because nowadays people, they actually have something called ghost publishing, which is where medical students will say, oh yeah, I have this submitted or in press, and then it never actually comes out. And so you got to be careful about that stuff, about making sure that your 10 or 15 are actually 10 or 15. But on one hand, it does help your application. On the other hand, it's a lot of time is a limited resource, and so just taking extra years and years and years, you want to make sure that it's worthwhile. You want to make sure that you have a good mentor, I think. Let's see, there's a bunch of chatting here going on. Let's see. Yeah, being a master student for Kiera, yeah, you want to make sure you're productive, and we can talk a little bit about how to find a mentor at your institution, other institutions. What would you recommend to substitute anatomy lab? Oh, that's tricky. During this Zoom world, there are different, I don't know about anatomy labs so much, because I don't know, it doesn't give you the feel of dissecting through the tissue and sort of just getting your understanding of it. But if you do have a skull-based lab at your institution, or in a skull-based neurosurgeon, usually skull-based neurosurgeons will have and want to have a skull-based lab, and that I think is very helpful to just even if it's just one-on-one or one-on-one or just by yourself, just playing around. Honestly, in a cadaveric head, it sounds gruesome, but it's better than playing around in a real person's head, in surgery. So that's one way. I think there's a website that had been called Head, Neck, Brain, Spine. And so you could go through there and really learn neuroanatomy, or neuroradiology. And neuroradiology correlates a lot with the neuroanatomy that you're going to be seeing. When we prep our patients, we always just see, we see them clinically, and then we see their imaging. And then you have to make this leap primarily during residency from being able to look at the imaging to know what that's going to look like under the microscope or in the endoscope. And I think being really familiar with neuroradiology is a really good foundation for that. And then to help you in that gap, going from neuroradiology to in the operating room, there are textbooks like Roton, and I think I have it right here. It's an important enough thing where I have it literally all the time. Oh, I have a weird thing on my screen, but the Roton text is a virtual screen. It does weird things, but I think that's a good way of decreasing that gap. And then there are resources like the Neurosurgical Atlas online that help you sort of go through. I think Dr. Cohen-Gadal does a great job of sort of taking people through that process. So hopefully that helps a bit. Hey, nice that someone's here from Philly. It was just up the road. I'm in Baltimore, Oklahoma City, and things like that. Dominican Republic, Turkey, Miami. Great. Questions regarding chances of matching without in America without a U.S. research experience. It is tricky. It's a little, and I'm not sure what USCE is. I know U.S. Research experience. I think to match in U.S. clinical experience. Yeah, I think it is something that, generally speaking, if you want to match in the U.S., you do need to have some research usually. You do need to have a clinical experience. And it makes it tough because you got to figure out, well, how the heck are you going to pay for it, and when are you going to do it, and how are you going to get the visa, and all these kinds of things. So sometimes what people will do is they will do a fellowship, a clinical fellowship. And that gets you some clinical experience, and it's a lower bar to cross than trying to get into residency. And if you do a good job with that clinical fellowship, then that often opens up doors. It's a long road. It's going to be a few years usually, but it does allow you a chance to get to do that. What kind of resources do you recommend for third-year clerkships? Yeah, I think Greenberg is a good source, but it's very thick, and so there's a book called Principles of Neurosurgery that is, let's see, I believe it's by Ellenbogen. He's one of the chairs he is the chair at University of Washington. I think that's a really good, it's a little more basic, I think. Greenberg is very thick and you can get lost in the weeds. Same thing with Roton. That's too much, I think, for third year clerkship. To publish in American journals, not so much. I think it's you don't want to have all lower tier publications, but I do think, yeah, I think it being in Journal of Neurosurgery, if you're doing something focused in neurosurgery, I think those are, if you're applying to American neurosurgery, I think those help. But there are wonderful journals overseas like Acta Neurosurgica and other journals. So I think and to some degree it's, yeah, you want to have quality, but it also is a quantity bit. And people can tell if it's all just quantity and no quality, you can tell, but you want to mix those up a little bit. Let's see. Letters of recommendation from foreign neurosurgeons. I think it depends who the foreign neurosurgeon is. I think it's a really small, tight-knit community. There's only a few thousand American neurosurgeons, and less than that probably who are in academics. And so, it's kind of like if you're going to recommend dating someone, right? If your friend tells you, hey, this person is great, you'll be more open to it. If it's just a random person that says, hey, this is great, even if it's, Anna de Armas or, whoever, Daniel Craig, you'll be like, well, I don't know so much. So I think it depends. Obviously, there are wonderful people overseas with a great reputation that are really known in America. And so some of those folks include like Ugur Turi from Turkey, Charlie Teo in Australia. There are a lot of wonderful neurosurgeons across the world, but I think it just depends on the particular person. Have I read any interesting books related to neuroscience? Honestly, I don't. This is just me. I focus mostly on just the clinical stuff. So I read papers and I read. I haven't personally read a lot, but I know, Henry Marsh has a really nice book on neurosurgery, When Breath Becomes Air, by Paul Kalanithi, I think is a really well-cited book, and the parts that I've read are extraordinarily thoughtful. So I need a lot of you to get into, for Hopkins specifically, again, I think it's similar to other institutions, where I think, if they're gonna, it's a job, right? They're married to you for 7 years for residency. So you do want to, they want to make sure that they like you, that they like you, that you're competent, those kinds of things. So, so I think it is helpful to have clinical experience either at the place that you want to go to or at a place that is well known, so that if you get a good recommendation from that place, it'll carry weight elsewhere. It'll carry weight elsewhere, yeah. Let's see, how much do you value students doing sub-Is? I think it's pretty important when possible. I think it's obviously, different this year with COVID, but I think looking at our complement at Hopkins, and I think also looking at the complement at other places, a lot of times it's people that are their home students or did sub-internships there or did research there or had really, really, really strong recommendations from known entities at other places. Let's see. Yeah, all right. Is that it?
No, we have some question that
sure.
they sent in the registration link.
Yeah.
Let me see. Esli Nájera, I'm not sure, sorry. Ask, what will you say is the biggest weakness one can find when you're applying?
I think it's something that is not easily put on paper, but in the second bit that I may get, the second set of slides I might go through if we have some time. But on there, it's after you pass that bar of so many publications and so many whatever board score. After that, the most important thing is the interview. How you interact with people. Are you nice to the administrative assistant when you're setting up the interview? Are you are you someone that has energy, that seems personable, that seems like no one wants to go to work with a miserable person for 7 years, So I think the thing that torpedoes people that would otherwise be excellent on paper candidates is being weird. I think it's being, just being an oddball. So you need to, you're still a human, and we're still, even though you may do fancy surgeries, you still need to talk to patients. You still need to talk to families before and afterwards. You still need to connect with your colleagues. And so I think forgetting that and just getting too lost, getting too myopic with, meeting benchmarks. In the end, it's not really about the benchmarks. It's about how you make people feel, I think. And so try not to lose sight of that.
I have a question, if you don't mind if I ask it verbally.
Sure.
So I was really intrigued, I guess, by the research you were showing regarding medical education and what ultimately leads people to matriculate into neurosurgery. I'm from Rutgers Robert Wood, by the way, so
hey,
I like the shout out.
Yeah.
What are outcomes that you would look at if you were doing shorter term meta research specific to neurosurgery, if you didn't have data to track people to see whether they actually ended up matriculating?
Yeah, so what we did, I didn't include it in anywhere in the presentation, but there's a paper that a medical student currently at Hopkins, his name is Saqib Huq. He looked at, and he's like one of the mission fellows now. He's involved in like AANS and things like. He's a really nice guy. So he looked at engaging. So he looked at sort of short-term, just before and just after, literally like a 2-hour session, anatomy session that we did, where the residents basically taught the first-year medical students right after their neuroanatomy lab how to do a retromastoid craniotomy, which gets you to see a lot of CP angle tumors, cerebellopontine angle tumors and cranial nerves. It's kind of cool. You get to see pica and 5 and 7, 8, and all this kind of stuff, all these nerves. So even with that, even with a like a 2-hour intervention, we demonstrated a statistically significant improvement in at least how medical students felt about the faculty member and about how approachable the faculty member and the residents were. It made people, it seemed to allow people to think that it was more likely for them to consider neurosurgery as a career, because they didn't seem like jerks, to be totally honest with you. And so we just did that last year, and then COVID kind of messed things. We were going to do it as an annual thing, and it kind of messed it up. But we're going to literally track those people over the coming years and see how things shake out. Like if their level of, if their baseline enthusiasm or their change in enthusiasm cause them to do neurosurgery or something related. So yeah, so I suppose the longer term stuff is to be determined, but I think if you look at that paper from World Neurosurgery, you could even use, like if you wanted to do a similar kind of thing at your institution, or if you wanted to do a joint thing with Hopkins and Rutgers and stuff, I think using that questionnaire might be, it's a relatively well-validated approach, because a couple other papers have used that too.
Thank you so much.
Sure. All right. What else? Other questions, or how do you want to shake it out?
We have a lot of questions from the registration link, but we want to share the presentation. The other.
We have 3 questions in the chat.
Yeah. So one of the questions. Let's see. When it comes to pass/fail step 1, let me get to that, because we actually asked program directors across the country about that. So let me get to that. Clinical fellowships in Canada. Again, it kind of depends on where who you're doing the fellowship with. So if you're doing it at a place that is really well known, like a pediatrics fellowship at Toronto or a functional fellowship at Toronto. I know Toronto just because I went there for a little bit. But I'm sure there are other places, but Toronto, McGill, those are sort of known places. Montreal Neurosurgical Institute, those are known places. And I think, it's kind of like, if your friend vouches for you, it means more than if just a random person does. So I think it depends. Practice. So that's the soft side of it. And then the practical bit of it is, it probably wouldn't help with regard to visa status and this and that. But at least if you went to a known entity, like at a place like Toronto or Montreal, I think, I think that could help. Is it real that you need 1 to 2 years of investigation to have better? Yes, I think so, to be honest with you. And I'll go through some of the data supporting why it's like 1 or 2 years, because that seems like a long time. Broadly speaking, I think 1 year is probably too short of a time period, because in 1 year, you can maybe if you really crank it out and you do a lot of clinical stuff, you could maybe get 30 or 40 publications if you do a lot of, I mean, that's I'm saying that based on a current postdoc at Hopkins who's outstanding. His name is Adam. He's literally going to have like 40 publications. It's outstanding. But you know, I think most people wouldn't be that productive. And you also have to remember, if you're only there for a year and you start in July, you're going to be applying in October. And so how are you going to have a meaningful, how are people going to be able to write a strong letter for you when they've only known you for a couple months? And it takes a month or two just to get used to where the bathrooms are and, you know, how to send email and things like that. So so usually the idea is to be as productive as possible in the first year. And then in your second year, continue to be productive, continue to work with other people, and then apply. During your second year, you would actually be applying. And so that's the usual protocol, I think, that has kind of worked. That's how I did it. That's how, you know, Adam's going to be doing it, and how a lot of other people that I think have already been successful have done it. At Hopkins, do you see quantities of American international? So at Hopkins, I think Hopkins is actually pretty open. You know, I think we have a lot of international medical graduates who have become residents. And I think a lot of it is because they do spend some time here. I think it's because we have some infrastructure that allows other people to come in, and it's a very collaborative environment. So there's actually a paper that we just submitted looking at our experience over the last 20 years, like back to the time that Dr. Quinones was here and even before, you know, because he attracted a lot of people from international, and where those folks are, where they are in American residency and overseas residency. So I think there is something about probably the name, the cachet of Hopkins, as well as the just our openness in our environment, our infrastructure, that allows an equal amount probably of international students to you know, really flourish here, probably equally to Americans. Yeah, so cool. All right, so maybe I'll go through a couple of these slides, and I'll go quick. I'm trying to speak quickly so that we have some more time to talk and stuff. So let's see. All right, so a couple others. So we talked about early engagement, then predictors of actually matching. So a few things. So the number of programs over time, you know, has increased, and the number of positions has increased. So that's good news. But the number of actual graduating US seniors, you know, sort of traditional American applicants that are actually successful in matching has dropped over time. Whereas those who are, you know, international medical graduates has remained about steady, maybe a little bit higher, but, you know, somewhere between, you know, 4 to 6% of applicants that match. So it's a small pool, but it is there. And then in terms of, you know, this is a univariate table. So I'm going to actually switch to this table, which is from the same paper, but it looks at the statistics of those that matched versus those that didn't match. So if you are applying and you can get about 15 interviews, you have a really good shot at matching. If you have, you know, 10 or less, you are not a great shot at matching. If you have a score in the 140s or higher on step 1 and step 2, you have a good shot at matching. If you're in the, you know, 120s or 130-ish range, it's tougher. If you have 10 or more publications, good shot at matching. If you have, you know, closer to 5, less likely. AOA may not be relevant overseas, and that's okay. You know, yeah, people who are at fancy, quote unquote, fancy schools have a slightly better shot. And MD PhD doesn't really rock the boat one way or the other, it seems, in your chances of matching. And so when you're thinking about whether to take extra years, you know, maybe don't use this data to maybe, unless you really want to do the PhD, don't do a PhD just to match, because it doesn't really statistically help you. Okay, but 240 or higher, aiming for 15 or more matches, 10 or more, you know, combined publications, if those are actually real. Those are the go-to points. Between between, you know, traditional applicants and international medical graduates, some of the main differences are related to USMLE step score. And so that's something, you know, you can't necessarily change if you're going to get a PhD or AOA or your volunteer experiences. Those are pretty equivalent. And sorry, this may be cutting off a little bit, but your step score, if you study hard and you get over a 240, that can help you. You know, it doesn't help you as much. So the dotted line is international medical graduates and the solid line is US medical graduates. So if a US medical graduate gets a 260 or above, they have about a 90% chance of matching, as opposed to an international medical graduate. If they get a 260 or above, they have maybe about a 50% sense of, likelihood of matching. So it's just a higher bar. And part of that is, because they don't, programs won't know necessarily how you are clinically. They wouldn't have had, people, their friends, essentially people they know, vouch for you. So look, these people are obviously outstanding, but it's not the same odds. And so it doesn't mean it's impossible, but it is good to have a bit of a, it's good to have the data, I think, so that you know what you're getting into. This is basically saying, the dotted line is for international medical graduates, number of places that they could rank, and it's all over the place a bit, and I think this has to do with, essentially who who are you familiar with, as opposed to for US graduates, which is this, the more solid line here. Essentially you plateau after 15, places that you can rank. Anything beyond that, and this data table keeps going out, but basically you have more than a 90% chance of matching if you're a US grad and you have 15 places that you can rank. Let's see, cutoff scores. If you have less than a 220, you're, most programs are probably not going to look at your application, unfortunately. And obviously, if you can get 240 or higher, earlier data shows that that's to your benefit. But you got to at least try to get a 220 if you can. And then with regard to USMLE, this is a paper that recently came out with Saqib and Adam and the rest of the group, including Dr. Huang, who's a program director at Hopkins, where we surveyed all the program directors across the country. And so, USMLE is going to pass-fail. And so, this is the raw number on the y-axis. So we wanted to get a sense of what program directors thought that would cause to happen. And so they think it's going to cause more people to apply. It seems like there's a trend towards thinking that it's going to cause people to do a little bit more research, maybe because they're not going to study as intensely because they don't need to for the test. Step 2 is probably going to become more important. A lot of people are unsure, but a lot of respondents thought that step 2, because that's still graded, is going to become essentially the new step 1. When it comes to that question that someone asked in the chat, should they take it, for pass fail, or should they take it for a score? The vast majority of people said if you have a chance to take it as a scored thing, you want to take it as a score. And especially if you're an international medical graduate, that can help you differentiate yourself in a positive way. And then, once it changes to pass fail, the more data that the program directors have, the better. And so the vast majority also recommended taking step 2 before submitting ERAS, which is your application. I think that's kind of, I'm sorry. Maybe a couple little things. Factors affecting resident selection. So this is out of Thomas Jefferson. Things that are not, so if you look at all of these, the gray lines, things that are relatively not important is the personal statement, is how you, when you're on a sub-I and you give an oral presentation, or whether you have a PhD. Those are relatively less important. Things that are more important are, the softer things, how you are in the interview, letters of recommendation, those kinds of things. And so that's what I was saying earlier is, obviously step 1 is important, but how you interact with the residents, how you interact with other people that write letters for you, and how you are interacting with everyone during the interview process, those are amongst some of the most important things. And when you look at, the factors that are most important, being high energy, being honest, having good verbal skills, being cooperative, those are the things that are important. Social skills, those are the things, interaction with residents at dinner, those are the things that really, once you get your step score and you get the number of publications, those are the things that really help you actually match. That's basically it. Board scores, take it for a score if you can. Try to do well in school, obviously, and if AOA is relevant for you and you're in the States, great. PhD, do it if you want to actually do it, but just doing it to try and increase your odds probably isn't a great strategy. Non-traditional applicants, and when I say that, I mean, folks who aren't US 4th-year medical students, unfortunately, do have a little bit more of a difficult time, but hopefully now you have some numbers that you can shoot for so that you have a goal. Don't sweat the personal statement too much, and the interview is important, just be nice. And that's basically the talk that I wanted to go through with you. And I think we have some time to talk and things like that. So I hope that's helpful. It wasn't going to be a revelation, but I thought rather than scouring the internet, at least and I'm happy to share the slides, and I guess it'll be on the video too. So you can have that as a reference. Let's see. let's see, thoughts on or prediction of how matching stats will change. I don't know. I think, we're at Hopkins, we're going to be looking at the virtual interview process and in ways that I probably shouldn't get into too much because we haven't fully vetted it out, but it is going to be different. There are some implicit biases that might, based on how, a person's camera looks, how their virtual background looks, if you can see their hands waving and this and that, based on how someone looks, whether they're wearing glasses or not, whether they're shaved or not. There's all these little implicit things that are different in a virtual setting. Obviously you get to save a lot of money with travel, but you don't get that interaction. And so because interaction is such an important part of how you get to choose who you're going to be with for 7 years, my prediction is probably that a lot of programs are going to be looking towards their home students or people that they're super familiar with already, rather than sort of taking a chance on someone that is an unknown entity, even if they have great scores. That would be my thought. And this year we did, I think a lot of programs had internal sub-Is for 6 weeks or 8 weeks, but yeah, you didn't get a chance to meet your future colleagues and things like that at other institutions. So that was a bit of a bummer, but I do think it's going to be more insular this year. I think you're going to probably be seeing a lot more students matching at their home programs or places where they did research or places where people are known. So yeah.
We have a question that was also sent in the registration link is how can you differentiate yourself from all of the other great applicants?
I think, look, everyone's going to have good scores. Everyone's going to have good publications, all that stuff. I think, if a good trick, I think, is maybe not a trick, a good frame of reference is, when you're doing work, when you're doing research, for instance, eventually, it's going to lead to, you being a resident and you being a faculty member. And when you go to become a faculty member, or when you're interviewing for a faculty job, you're going to have to give an hour-long, what they call a job talk. And I think it's a good idea to be known as, a such and such person, a brain tumor immunology person, or an outcomes person, or a, robotic spine person. You want to sort of have some specialty interest. If you just do, if you do one functional, as a medical student, if you do one functional paper and one spine paper and one tumor paper and one this and one that, it's hard to sort of, it's harder for people to envision what you would be, what your interest would be in residency and what kind of a faculty member, what your primary contribution is going to be. And so I think it's nice to be able to sort of frame a story around why you're interested in something and sort of pursue that to its fullest, to whatever extent you can. And I think it's a little bit of a balance because you do want to get to know people. You want to know a diverse number of people at your institution. If you only know one faculty member, that person may love you or hate you, but you need to work with the other dozen people in your department. So you need to balance working with, or at least getting to know people in your department with really having a focus, a clinical focus or an academic focus, with the idea that, hey, in a few years, I need to fill an hour with my work. And so, as a medical student, it may start with a case report and then maybe a case series. As a resident, it may transition into translational work or basic science work or something like that. But I think that helps differentiate people. Not so much getting a PhD, but having an area of interest or focus that makes sense and that is longitudinal over at least a couple of years.
We have a great question from Gustavo, our president.
Okay.
Do you want to do it, Gustavo, or?
Yeah, Gustavo, are you around?
Yeah, sure. I was wondering what can we do as an international student chapter for the American Association of Neurosurgeons? What can we do with or for our students to increase their chances to match in a U.S. residency program?
Yeah, I think, to be honest with you, I think Anna's doing a great job. I think a lot of it is, people, I know you and Jeremiah knows you and people know you. So, and so I think if you continue on that trajectory, not to single you out, but in a similar way, I think, I think Anna has done a really good job of using the opportunity that AANS has presented. She followed through. She comes up with interesting ideas. She follows through. And if you do that, then people are more prone to say, okay, can you do this and help out with this? And then, pretty soon you get to be on webinars with Quinones and, Jeremiah and all these people, who are at all these different programs. And I think, I honestly think getting involved with the Young Neurosurgeons Committee would be a great way to be involved. And I think, we're trying to do more things like with social media and webinars and this and that. And it's little things, but if you follow through on those little things, you'll get noticed. And I think, and it's a little easier to work. I think it's a little less intimidating to work with a young neurosurgeon, relatively young neurosurgeon, than, a chair of a department who's like in their 70s, and so, so I think that's a really good way. And also it sort of diversifies your portfolio, because then you get to meet people and interact with people from, for instance, last week's webinar was, I think, Wake Forest, Emory, Baylor, folks at Michigan. It's a fantastic way of getting involved. That's what I would say.
Thank you, Doctor. It was, it's my pleasure to work with you and Dr. Johnson and, Dr. Calafala. He's great.
Yeah.
Really
So,
great.
and look, you have to remember too that the people that you're going to be working with they're neurosurgeons. They're like full-time neurosurgeons, so they're busy people. So I know you guys are busy too, but like we often will drop the ball just because like we have so many emails and like we're scrubbed in surgery for 6 hours or 8 hours, and so even little things, if you follow through with, it's huge because it saves us. We're strapped pretty thin, or stretched pretty thin, I should say. So, so it doesn't take much. It doesn't take much to impress us, I think, for whatever it's worth. Yeah, but nevertheless, Anna is very impressive. So I didn't mean to.
Yeah, she's
You, Doctor.
Yeah. Kiara, yeah, feel free to shoot me an email anytime. I try to get back to folks within a day or so, but sometimes if I don't get back to you, feel free to just email again with a gentle reminder kind of thing. What else? Any other questions or comments?
I have a more personal question. Maybe I don't know. Maybe later, can we meet later? I don't know.
Sure. Yeah, anytime.
We have also questions about your path to becoming a neurosurgeon. If you had any problems and how you overcome these problems and sort of
Yeah, I mean, I think I thought residency was. It's always tougher than people. Folks on the mountaintop, if they want to keep their mystique, broadly speaking, they're not going to tell you about the troubles that they had, because it takes, because everyone wants to, it was arduous. And so why make it seem like it was easy, or, why make it seem like it was arduous? You want to make it seem like you're Superman. But truth be told, yeah, everyone has hard times. I think residency was physically very grueling. It was very tough. I think this is going to go on the internet, so I don't want to, like, maybe forever and ever, so I don't want to go into particulars maybe about who caused me problems, but oftentimes your co-residents can make your life very difficult, if they're so I think when you're interviewing, it's good to know who your try to figure out what your co-resident class is like, and maybe who your specific chief is going to be. And I think, because you don't have a huge amount of control over everything, but if you know that you're not going to get along with, if you meet them for a day and you just don't want it, don't like their energy, let that sink in. You should include that in your rubric, because they can really make your life terrible, especially as a, PGY2, which is to PGY 1, 2, 3, usually, depending on the program, can be a really difficult physically time period. Really arduous stuff. And so whoever your chief is going to be during that time, I think it's important to keep track of that. And then the rest of the stuff, it's, I think it's nice to try and train near family or friends. So I went to Los Angeles to train, and I didn't really know anyone. I had a high school friend that I reconnected with there, but over time, my family actually moved to LA, my sister, and then my other sister, and then my parents. And that made it so much nicer, because you are going to be really busy. And I think to have holidays and those kinds of things, whatever little time you have, if they happen to live in the same city or in the same area, it makes life a lot more joyous, I think. So those are some tips I think might help. Yeah. What else?
We have more questions. Let me see. What advice? Well, you have advised us a lot, but what other advice can you give for medical students who are interested in pursuing career neurosurgery, but they are early in the.
Oh, yeah. I think don't be shy. Sometimes I was shy about, well, I don't know if I'll have the grades or the scores, or I don't know if I'll be able to dedicate all this time to it, and I don't know if it's the right fit. But especially early on, there's a freedom to being early on, because you can really just explore. You can come and go, and there's nothing wrong with exploring. I would say if it comes to a specific project though, and you say you're going to do something, you really should just do it. But there's nothing wrong with shadowing. I think that's a good way of sort of getting a sense of what the culture is like and what that person's personality is like before you commit to a project. So that's a good way, I think, of early on. Spend a day or spend a weekend on call or something like that. I think that gives you a sense of the personalities at least involved, just to get a sense of if it's something you even want to spend 30, 40 years doing. So.
We have another question. What called you to neurosurgery over other specialties? Yeah,
so for me, it really was personal. I didn't think I was going to be a neurosurgeon. I thought I was going to, my dad actually said that, my sister one of my sisters is a nurse, another sister is a internal medicine doctor. And he's a dad and he loves his kids. So he said, well, internal medicine doctors, they're the smartest, they're the best and all this. Okay. And so I was starting medical school, and he would actually say that, surgeons, they're just butchers, they just cut and this and that. They don't really know. And so that's kind of how I felt for a long time until, until there were some family members of mine that, like the family friend that I mentioned that had a tumor, and someone close to me had hydrocephalus and then a head bleed, and all these kinds of things sort of came up. And so it genuinely wasn't of my own volition where I sought it out, but seeing how impactful those neurosurgeons, their wisdom, their judgment, their kindness was, it totally changed the trajectory of my family members, and it totally changed the dynamic of my family for not just those handful of days, but for decades afterwards, because they're still alive now. And I don't think that those people wouldn't either be alive or they wouldn't be alive in the same way if it wasn't for those people coming at that particular time, in my life and in their lives. And so, for me, I always wanted to go into medicine just personally. It's an expression of gratitude. That's why I wanted to do it. It wasn't for money or fame, or because honestly, it wasn't even because of the science. I know a lot of people say, oh, it's neuroanatomy and this and that. But for me, I wanted to figure out, what did I want my contribution to be in medicine? And so it happened to be that I saw these people, these neurosurgeons, totally changed my life. And I had a really wonderful mentor that cared about me like an older brother. And it's because of them that that's where that inspiration comes from for me. So yeah. Sorry, see, you ask too many personal questions. See, that's you gotta just keep it broad, otherwise,
Sorry.
Yeah. But that's the truth of the matter. So for me.
Yeah. I know you have a meeting, but just wanted to thank you for being here and giving this great talk, and talk also about yourself. And thank you, doctor, for being here with us.
Sure. It's an absolute pleasure. It's an honor and a pleasure. Like I said, because of Dr. Quinones, that's it's because of his guidance and his mentorship that I'm here. And so he was always really warm and caring and open to anyone that was interested. And I'm just trying to have the same outlook, because he changed my life. So for anyone, even if we didn't interact or talk or whatever, I think hopefully you'll see my email address on the video thing. So just shoot me a message anytime. I can't promise I'll get back to you that minute, but I will get back to you. And I think for Josue, I don't know if we may close out before. I think he sent me a private message. So if you can, just shoot me an email, because I don't want everyone to look at me reading your thing, and then it doesn't make for good TV, you know. So, but just shoot me a message, and I'll get back to you. I promise. Okay. All right. Anything else, guys? No. Okay. Look, it was a real honor and pleasure. Okay, so please be in touch, and it's a small community. Okay, so we'll see each other again.
Thank you
All right.
so much.
Cool.
Thank you.
See ya. Bye.
Thank you for organizing this.
Mhm.
Yeah, thanks, Anna. Thanks, everybody. Gustavo and everyone. See ya.